I'm going to kick us off and welcome everyone and good morning. Happy winter. I've stopped saying Happy New Year. Happy winter, looking forward to spring. And thank you all for being here. We have a very, very special rounds today. Very special in my opinion. And anyone's welcome to make announcements and just, let us know, raise your hand or chime in. But let me announce our upcoming grand rounds. February 9th, we have two presenters of our early stage investigators, and that will be Fernando Montero, talking how xylazine is transforming the harm reduction landscape for people who inject drugs, and Emily Payne talking about as long as they're in the shadows, they're taken advantage of, how economic marginality shapes access to HIV prevention and care among trans and non-binary people in 3 US cities. So that's February 9th. And then our second rounds in February will be February 23rd. And this will be Adam Carico from Miami, Bridging the Divide, Optimizing Biomedical HIV Prevention from Cytokines to Society. Just pause for a moment to see if there's any other announcements, or if Stephen or Teo have an announcement. And if not, I'm going to introduce very briefly our two speakers today. And we're very, very blessed and pleased to have with us two people to present today's rounds. And they're talking on integrated strategies when addressing methamphetamine use among men who have sex with men living with HIV or with HIV risks. And our two presenters will be Dr. Stephen Shoptaw and Dr. Jeremy Kidd. Steve Shoptaw, I could go on and on, Steve, and I won't, but I'll just mention your primary appointments. You're a clinical psychologist and professor in departments of family medicine and psychiatry and behavioral sciences at UCLA. Steve is the PI of our sister center, an NIMH-funded center like our HIV center, and their center is Center for HIV Identification, Prevention, and Treatment Services, known as CHIPS. And he's, in my opinion, a very leader in the field and successful leader of that very important center. And I'll mention he's got other, Steve, you just wear too many hats. I mean, you're an honorary professor in the Department of Psychiatry and Mental Health at the University of Cape Town, executive director of the UCLA Center for Behavioral and Addiction Medicine, vice chair of research, Department of Family Medicine. I don't know how you do it all, Steve. I will say that Dr. Shoptaw is really a leader in the field, very active in HPTN networks and other federal networks. He leads research on clinical and policy efforts to bring novel and high impact strategies to deliver culturally competent care and prevention for persons affected by addictions, and also is a wonderful mentor to emerging clinical and research scholars from diverse backgrounds, both in the US and globally. And thank you so much for being here, Steve, and especially getting up so early on the West Coast. And he will be presenting along with someone from here, from Columbia, Dr. Jeremy Kidd, who is an assistant professor of clinical psychiatry in the Division on Substance Use Disorders here in Columbia and at NISP, New York State Psychiatric Institute. For over 15 years, his research is focused on the intersections of sexuality, gender identity, and substance use to address substance use disparities among lesbian, gay, bisexual, transgender, and queer populations. And I'll just add, as an addiction psychiatrist, he also provides clinical services as director of the Addiction Consultation Service at the NISP Washington Heights Community Services right here in our local community. Thank you both for being here. I'm going to turn it over to you. Reminder to all of our attendees to be on mute during the presentation. You can post questions in the chat and or ask them when the time comes. And as usual, Stephen Sukumaran will be facilitating the Q&A. So over to you, Steve and Jeremy. Thanks for being here.
Oh, Bob, thanks. That was amazing. And first of all, you are amazing. It's just incredible. It's such a privilege and an honor to be asked to be here. Thanks to you and to Teo and to Stephen. So it's just wonderful to be here. The rationale for today is the simple question of thinking about not what we've done, but what we need to do going forward. And some of the conversations that Jeremy and I have been boiled down into simple things. And it's driving our work here in Los Angeles. And I hope it'll help drive the world and the work in the field. And the simple question is, where do gay and bisexual men, or MSM, meet? It's a different sort of question that we can answer. Since the pandemic, things have shifted. It's easy to find sexual hookups. There's sites on the internet, and they're always developing new ones. And on these sites, methamphetamine co-occurs among some of the men who use these sites. But the question comes back to, where is health? Where is the place for social, non-drug related connections for gay and bisexual men? We're going to focus on health today. That's going to be we're not looking at pathology. We know Jeremy's going to talk a little bit about interventions and how we can manage methamphetamine use within the setting of the culture of gay and bisexual men, and really take our thinking to the next level. So this is not about what we've done. This is what do we do next? I do want to say it's been my great good fortune to meet Jeremy Kidd. I met him through the CTN, and he took a very important data set and asked a simple question of like how gay and bisexual men respond to a medication treatment. And that led to a paper, and it's being published, and it's just generating all kinds of things. And it's just such a nice thing to have Jeremy being not only a colleague, but a friend. So with that, we'll get started. Next slide. Here are my disclosures. Next slide. Today, we're going to talk about epidemiology. We're going to talk about recognizing treatment and prevention interventions with efficacy for MSM who use methamphetamine. I like, this terminology is always troubling. Sexual minority men, men who have sex with men, and then gay and bisexual men. I like the term gay and bisexual men because it carries culture with it. And so I really want to focus on that. But because gay and bisexual men may or may not be, and men who have sex with men, or sexual minority men may not be men who identify with gay and bisexual community or culture, we're using the behavioral terms this morning. We're going to understand the ways to integrate pharmacotherapy, behavioral and harm reduction interventions into health for men who have sex with men living with HIV or with HIV risks. Okay, next slide. So looking at the prevalence of methamphetamine, still the best paper that's out there right now is Michael Farrell's Lancet paper from 2019. It's getting a little old and long in the tooth. It's getting kind of dated, but it has hundreds of studies in this review that are recognized and organized. One of the sections that is devoted to methamphetamine prevalence in this paper relates to gay and bisexual men and men who have sex with men. So I like to highlight this piece. And in terms of looking at the prevalence, the highest prevalence of methamphetamine use is in Australia. The darker colors indicate higher prevalence. Next comes the United States, Southeast Asia, and parts of Western Europe. Next slide. In the US, the most recent data that's out there is showing that methamphetamine prevalence is less than 1%. And it's not, it seems like all we hear is methamphetamine. You think prevalence is going high, but in the latest data, that bottom flat line just above 0%, just below 1% is what the prevalence across the population is. In subgroups, methamphetamine prevalence is increasing, and these include people who also using heroin, which is the higher line, and people who use LSD, which is the middle line. And this work is Joey Palomar's, and I just want to say it's always great to have a colleague like Joey as well. He's a tremendous person working in New York. I think one of the things that's sort of new in my thinking about epi and looking at understanding how epi works is this paper by the Maryland group here that was published in Addiction. It's worth downloading. I don't want to spend time with it, but in terms of understanding methamphetamine prevalence in subgroups, it can be very difficult to use the national household data and other sorts of national surveys. So this is kind of through a glass darkly, and we see that. Next slide. What we also see is that among methamphetamine, that STIs, sexually transmitted infections, are common. And this has been going back for a long time. But a recent review by Kathy Reback, my community partner, shows that, among men who have sex with men in Los Angeles, chlamydia, gonorrhea, and syphilis are highly prevalent among men who have sex with men. And in a nationally representative sample of US adults who use methamphetamine, we can see increased prevalence of STDs, HIV, and hepatitis B or C. Next slide. What we also see here, that one of the things that's happening in Los Angeles is our public health department is getting better with geospatial location of different epidemics, kind of that syndemic idea, seeing that syphilis, methamphetamine, and HIV co-occur. For those of you who are not familiar with Los Angeles, those red dots were the highest clusters of HIV diagnoses. You can see that's downtown. That's the downtown region. The red cluster on the right, a little lower than the one on the left, is downtown. The one that's up a little higher there is Hollywood. And then you can see that there's other clusters that go down, which are in the Figueroa corridor, cutting through South Los Angeles, the minority community in town, and into parts of the South Bay. One of the things that's important to take from this is, in terms of plotting methamphetamine use, we see that about half of cases of HIV correspond with syphilis, and another 18% have a history of methamphetamine use. So it's really this syndemic idea, and when you plot these syndemics, they all fall on top of each other. Next slide. In comparisons of gay and bisexual men and heterosexual men across all substances, Wilson, Compton, Christopher Jones, in their New England Journal review, showed that across all of the substances, gay and bisexual men had higher prevalence, and across some of the substances, we see substantially higher prevalence. And particularly pay attention here to methamphetamine, to the stimulants, prescription stimulants, opioids, cocaine, hallucinogens, and marijuana. And among alcohol, heavy drinking, and tobacco, the difference isn't that great. Next slide. One of the things that we've found in the past few years is that methamphetamine is moving into populations that prior hadn't been involved. Among Black men who have sex with men in Baltimore, we've seen methamphetamine use go up in prevalence. This is something I've personally watched over the 25 years of my career. Baltimore didn't have methamphetamine in the late 90s, early 2000s. Now they do. And among men who have sex with men who are Black, African-American, living in Baltimore, what we see is corresponding and parallel mapping of these syndemics, where among people living with HIV, methamphetamine use is very high, as well as syphilis. Next slide. So some important early observations that came out of all of this epi, next slide, was something with my community partner. She published and organized this work, Kathy Reback, in The Social Construction of a Gay Drug. This is a social ethnography paper that in 1997 is as relevant today as it was back then. And in fact, I recommend that for people who are entering this group not to propose to do a lot more social ethnography to understand this construction of methamphetamine in gay community, because it's not changed. It's pretty much the same. There are things around the social construction that are different, but the whole ideas of identity, sexual functioning, boosting of confidence, productivity growing, strong body experiences and weight loss, brightened mood, and dealing with aging and the issues of living with AIDS, those are as current today as they were back when I was a kid. And so it is really interesting to see that happens, and it's pulled through, and it's that concept really hasn't changed much. Next slide. One of our community partners back at that time, back in the day, had a very provocative slide that they used in advertising recovery services, which really shows, I was so tweaked, I didn't care how he screwed me, really showing the sort of link between sex and methamphetamine and a reduced and increased risk of sexual behaviors. Next slide. this idea about sex and drug was current back in the time when I was starting my career, but it's been refined now to this idea of chemsex. And chemsex is an important distinction between sex that just occurs when you're high. Chemsex is defined as using a certain substance immediately during or prior to sexual behavior to facilitate an experience that is different than sex that doesn't happen under the influence, or sex that happens when not using drug. There are several drugs. We don't have methadone in the United States, but in Europe, methadone, methamphetamine, GHB, GBL, the derivatives of G are out there. And then ketamine are sex drugs for chemsex. In the US, it's mostly cocaine and methamphetamine, and among minority racial and ethnic identities, it's often cocaine. It's more prevalent among MSM who are living with HIV than MSM who are not living with HIV, and we see that prevalence being substantial. Some of the reasons why that is because if you're having chemsex, you're living without HIV, and you're using methamphetamine for part of your chemsex, it's really a matter of time until you become infected. We do see that there's some great data on PrEP where men who are having chemsex are using PrEP reliably, but still it's amazing to watch. We see an incidence here of 3.4 to 4% in Los Angeles among men who are using methamphetamine. So it's a substantial risk. Next slide. And in the review of chemsex, I'm not going to spend a lot of time with this, but I will point you to this paper. It's a really nice review showing that the antecedents of chemsex and then the behavior, about 3 to 29% across the studies are shown to engage in chemsex, substantial number of people within the gay community. So thinking about the larger gay networks in New York, you can think that between 3 and 29% of men are going to engage in chemsex at any time. So that gives you a sense of the size of the group that's involved, and then the sorts of behaviors that go along with it, extreme forms of sex, esoteric acts, condomless anal intercourse, multiple sex partners, injection and sharing of needles, and then, of course, the consequences we talked about. Next slide. So at this point, I want to turn it over to my partner in this work, Jeremy.
Thanks, Steve. Thanks to Teo and Bob and the HIV Center for the invitation to present today. I want to say it's been a real privilege getting to know Steve, to benefit from his mentorship and friendship throughout this process. And I'm just so excited to be able to present with him today. So in the next part of this talk, I'm going to talk about integrating evidence-based strategies for treatment and for harm reduction of methamphetamine use disorder. We're hoping to show you a clip of this documentary, Crystal City, that came out in 2019, but because of some technical difficulties, we're not going to, but I really encourage you to check it out. It's available free online on streaming services that I won't mention because I don't want to advertise or endorse them, but you could Google it and find it. And it's really about crystal meth use in New York City. And it really echoes much of what Steve was saying, because this was released in 2019. And you'll see folks talking about their experience of use and their experience of recovery. And they really parallel that 1997 paper by Kathy Reback about the social construction of a gay drug, and really reinforce that the reasons that people are using haven't changed all that much, although some of the context maybe has around app-based hookups and those kinds of things. So just to contextualize where intervention research has been when it comes to LGBTQ populations. So back in last year, my colleagues, Drs. Margaret Passion-Wolf, Tanda Hughes, Cindy Veldhuis, and Casey Jackman, and I reviewed all intervention studies for substance use among LGBTQ people between 1985, when the first HIV antibody test was released, and 2019. And you can see that it's really great that around 2006 or 7, we see this real spike in intervention research moving from description to intervening. Unfortunately, all but 5 of these 71 studies were among gay and bisexual men. So we still have a lot of work to do when it comes to interventions for sexual minority women and for trans and non-binary folks. But among these interventions for gay and bisexual men, over half of them were focused on methamphetamine. All but 2 were conducted in the US. All but 1 focused exclusively on cisgender MSM, only 1 focused on trans MSM. And the majority of these, 19, focused on individual in-person psychotherapies with or without medication. You can see a variety of others that were examined in smaller interventions. There have been some subsequent really important medication studies to 2019 that we're going to talk about a little bit later as well. About half of these were randomized control trials, and 19 of them showed positive outcomes. And the reason I show you this is because of the intervention trials, methamphetamine really has been where the focus has been, but the kinds of interventions that are looked at are not all that heterogeneous. In particular, contingency management is a behavioral intervention that predominated in this review. And contingency management, for those of you who aren't familiar, is based on principles of operant conditioning, uses increasing valuable, typically financial reinforcers to reinforce abstinence outcomes, usually drug-negative urine drug screens. So the focus here really is on abstinence and promoting abstinence. Cognitive behavioral therapy, which many of you are probably familiar with, skills-based work to develop strategies to instill abstinence and prevent relapse. Combinations of those interventions, which we're going to talk about a particular manualized intervention based on combination CM and CBT, and then culturally adapted interventions, and here highlighting this gay-specific CBT that the Friends Health Center that Steve and Kathy Rebeck prominently have examined and studied, and are now moving into app-based and sort of gamified adaptations of, which is really exciting. So as an illustration of this work, this is a study from 2005 that Steve and Kathy Rebeck and others conducted that was a 4-arm randomized control trial or randomized trial of cognitive behavioral therapy, contingency management, the combination of those 2, and then a 4th arm, which was this gay-specific CBT that we'll talk a little bit more about on the next slide, for MSM who met DSM-4 criteria for methamphetamine dependence. The top graph on the left shows the average number of meth-negative urine drug screens during the trial, during the 48 visits. And you can see that the contingency management arms, the green bar and the yellow bar, outperformed the CBT arms in terms of average number of drug-negative urines during the trial. Interestingly, and this is illustrated in the graph on the right, this shows average episodes of unprotected receptive anal intercourse in the past 30 days at each study visit. And here you can see that it was the contingency management arm that outperformed, the CBT arm that outperformed the contingency management arm. The CBT, the gay-specific CBT arm is those white boxes there. And so the takeaway here is that CM seems to be superior for helping MSM who use methamphetamine initiate abstinence, and CBT seemed to be more effective in modifying HIV risk behaviors. Interestingly, and also really importantly, this graph on the left at the bottom shows the percent negative urine, meth negative urine samples at 12-month follow-up. And we can see that all of the arms are roughly equivalent at that point. And this sort of illustrates what's been described in the depression literature as sort of the sleeper effect of CBT, where there was sort of some catch-up that happened there. But this sort of helps us think about how to combine interventions, whether we're focused on initiation of abstinence, maintenance of abstinence, or HIV risk reduction. And I want to give a shout out to Steve and Kathy and others at the Friends Community Center for the Getting Off intervention. This is the manualized adaptation that I mentioned that pays particular attention to sexual functioning when reducing or stopping methamphetamine use, adapting specific distinctions between populations like MSM, where chemsex is a prominent feature, and maybe other communities where it's not, monitoring for the ways in which discussions of chemsex during treatment may actually serve as triggers, and then paying special attention to the ways in which social and sexual networks for MSM who use methamphetamine become almost exclusive and restricted to individuals who they're using with or who are using methamphetamine. And so making changes to methamphetamine use can mean can have really profound consequences for individuals' access to social support and sexual networks. And keep an era, we just, Margaret Passionwolf and I received a small grant from SAMHSA through the Opioid Response Network to work with Kathy to develop an in-person training for frontline treatment providers in the getting off intervention. And we're going to be offering that to providers in New York City and then in a hybrid format around the country later in the fall. So we'll be sure to share that with those of you who might want to participate in that. But transitioning a little bit to harm reduction, because traditionally, interventions for meth among MSM have focused on abstinence as the primary outcome. Generally speaking, this is where NIDA has been when it comes to methamphetamine studies, that abstinence has been the primary outcome. But what about MSM who either can't achieve abstinence or who don't want to stop using altogether? And as a clinician, I can tell you that this is the majority of the people that I work with, that the majority of people are either not ready or not interested in stopping altogether. And is there a way to improve the pleasure to risk ratio for meth use among these clients? This is something that Carl Hart in his recent book, Drug Use for Grownups, termed pleasure maximization as a way of sort of reframing harm reduction and sort of focusing on how do we help individuals who are using meth get the stuff that they're looking for and reduce the unintended or related harms that might come from that use. I sort of think of this and Steve and I sort of conceptualize this in sort of two buckets of harm reduction. So there's infectious disease harm reduction and then drug use related harm reduction. Of course, we have the things that you all are all familiar with, and I don't need to belabor talking about condoms and PrEP and PEP, I think, to this audience, but they're really important to think about in individuals who are coming into treatment for methamphetamine or who are using methamphetamine. Integrating HIV and STI and HCV testing into settings where MSM who are using meth are coming for care. And the CDC recommends testing every 3 months. And then integrating meth stimulant screening and brief intervention in the other direction into clinics that are serving MSM who are coming in for HIV and STI testing. So making sure that we're talking about meth in sexual health settings and making sure that we're talking about sexual health and infectious disease prevention in settings where we're talking about methamphetamine. For people who are living with HIV, harm reduction includes considering strategies that can improve ARV adherence. We know that chemsex is associated with reduced ARV adherence and worsening HIV outcomes. So thinking about single pill formulations, long-acting injectables, things that people might have an easier time keeping up with and would be less likely to be disrupted during episodes of chemsex. Emphasizing condom use, particularly in the context of booty bumping or anorectal use of methamphetamine, and providing education to people that even if they're not going to use condoms in other settings, that anorectal use results in tears in the anal mucosa that can really increase the risk of HIV and other STI transmission. And so this might be a time when they really want to think about using condoms, even if they're not in other settings. And then helping people talk and explore ways to shift to non-injection drug use as much as possible, even if they're not shifting completely. And then we can think about harm reduction based on the mode of use as well. So the theme throughout all of these, whether we're talking about safer injection or safer smoking or safer snorting, is really using sterile supplies to inject or smoke or snort. In New York City, you all might be aware that there are syringe services programs. There's this website thepoint.org rather, that you can go to and clients can go to and type in their zip code and find places to get sterile syringes and other supplies. In New York State, pharmacies are also able to dispense 10 syringes without a prescription, no questions asked. Although I will tell you anecdotally, having tried to do this just to see like what it's like, there's definitely hesitation or stigma there. And so I think helping clients navigate that and be prepared for how to use that system can be really important. Also rotating injection sites to reduce infection risk. When it comes to safer smoking, it's a continuation of this theme. We want intact mucosa, we want intact skin to prevent infection. So reminding people to use lip balm when smoking, because that reduces the risk of cracked lips, which reduces the risk of infections. And when it comes to safer snorting, so many people use dollar bills to snort, but that's really terrible from an infectious disease standpoint. We think about how many people handle money and where money goes and how unclean that is. And so talking with people about using Post-it notes or clean paper to snort instead to reduce infection risk And I can tell you, when you start talking about harm reduction with clients and sort of acknowledging that they're going to continue to use, it greatly improves your therapeutic alliance with people. And they're much more engaged in treatment because you're really meeting people where they are and where their goals are, as opposed to preaching abstinence, which may not be a good fit for the person in front of you. And then thinking about drug-related harm reduction and thinking back to that slide that Steve showed about the increase in methamphetamine use among people who are using heroin and other opioids, as well as the increasing rates of fentanyl contamination in methamphetamine, we really have to think about opioid overdose prevention, and naloxone really being the mainstay of that, and bystander naloxone training. So just a reminder that in New York City, we have opioid overdose prevention programs that distribute naloxone for free to you, to your clients, to whoever, and you can find those at this website here. By prescription, you can prescribe it, and there's a copay assistance program where New York State will cover $40 of the copay. People can also purchase it over the counter at pharmacies, though that tends to be cost prohibitive for many folks. And I included a link here that we'll send with the slides where this is a training video that I use with my patients and my clients to talk about how to recognize overdose and how to use naloxone. And this can be a really important tool for people to be empowered to take sort of overdose prevention into their own hands. Drug checking has become more important than ever when it comes to methamphetamine, again, as a result of fentanyl contamination. So drug checking refers to the self-administered testing for potential contaminants. We know from studies that unexpected results, so an unexpected fentanyl positive test can impact drug use behaviors. Either people won't use, or they'll use a smaller amount, or they'll use with other people, or they'll carry their naloxone. That testing really can result in people changing their behaviors. And this photo on the right is courtesy of Dr. Chelsea Shover and displays the use of FTRI machines for community-based drug checking at syringe services sites, so people can bring their drugs in and check them for the presence of fentanyl or other contaminants that might impact their use and their safety. And then another aspect of harm reduction is reducing the risk of overamping. The slide on this graphic displays the symptoms of overamping, which are really the unintended, undesirable physical or psychological effects of drug use. And we know that overamping is more likely to occur when individuals haven't slept well, have poor nutrition, are dehydrated. When they're combining routes of use, such as smoking before injecting, and when they're combining other stimulants with methamphetamine. So this is an opportunity to help our clients think through the ways that they're using and the things that they can do to reduce the risk of undesirable effects. Having worked in the psychiatric emergency room for a number of years, most of the presentations that we saw for individuals who use methamphetamine were a result of overamping, so intense paranoia, anxiety. And these can be really traumatic experiences for people too. They can be really scary, and people can even develop suicidal ideation because of the paranoia they're having is so frightening. And then finally, before we talk about medications, we're going to talk about tobacco cessation as a method of harm reduction too. I just wanted, this graph shows crude mortality rates among different groups of gay and bisexual men who use methamphetamine. And I want to just draw your attention to the bottom here, where we have a 3.4% mortality rate per 1,000 person years among gay and bisexual men who use HIV. That mortality rate jumps to 6.9 when we're talking about gay and bisexual men with HIV who smoke tobacco or use tobacco. That's a huge increase in mortality. And so even among individuals who, if we're not doing anything to their HIV care, if we're not doing anything to their methamphetamine use, if we can introduce evidence-based smoking cessation, which again, pharmacotherapy is a mainstay of, we can really impact mortality rates among gay and bisexual men who use methamphetamine. And then as Steve was saying, we want to sort of end this talk by thinking about like where we're hopefully headed in the field and like where the research can go, and integrating pharmacotherapy as a harm reduction measure. We know that there are no FDA-approved medications for stimulant use disorder, but there are some investigational medications with promise. And the first of those is mirtazapine. This is a study by Philip Kaufman and others that was published in 2020 in JAMA Psychiatry, where MSM and trans women who use methamphetamine were randomized to mirtazapine 30 milligrams at bedtime versus placebo. Both arms received CBT and MI-based counseling, and the primary outcome was the trend in methamphetamine urine drug tests over the course of the study. And you can see here that, these drugs, I want to introduce them as harm reduction strategies because none of these are a panacea. These are not, the effects are positive, but they're not like out of the park. So, but you can see here that this yellow line representing mirtazapine, we do see a statistically significant difference in the rate of decline of methamphetamine positive urine drug screens in the mirtazapine group at 12, 24, and 36 weeks. So this is a positive study. But again, we're thinking about how can we help people reduce their use? How can we combine this with behavioral and other harm reduction interventions to really achieve the outcomes that we and our clients want? The next is naltrexone, which is sort of a complicated story. So this is another paper by Philip Coffin from 2018, where individuals were randomized to extended release naltrexone. So this is the injectable naltrexone, 380 milligrams every 4 weeks, and followed same outcome and same behavioral platform as in the mirtazapine study. And here, this was really a wash. So there was really no difference in methamphetamine positive urine drug screens between these two groups, between the naltrexone and the placebo groups. So this was, I'm sure, disappointing, but this study provided, I think, some preliminary data for the next study that was done, which was to combine naltrexone with another medication, bupropion. So naltrexone we can think of as kind of an anti-craving medication, and bupropion has stimulant-like properties. It's often used off-label or second line for ADHD. And so this was a study of combination extended release naltrexone with high-dose extended release oral bupropion. And in the interest of time, because I want to make sure that we have time for question and answer, this was a 2-stage trial in which individuals were randomized to active medication or placebo for 6 weeks. At the end of that first stage, individuals in the placebo arm who had not responded to medication were re-randomized and followed for an additional 6 weeks. And then the treatment outcome, which was again based on stimulant-negative urine drug screens, is the weighted average of the response rate in each of those stages. So you can see here this green bar shows the weighted average response rate of 3.6 in the naltrexone bupropion group, statistically and I think clinically significantly larger than the 2.5% in the placebo group. This was not a study of MSM specifically. This was, I think Steve mentioned the study at the beginning. This was a study of men and women across the country at 8 different sites who were using methamphetamine and had methamphetamine use disorder. But Steve and I looked at this data and said, is there a difference between the MSM and the men who have sex with women in this study? And I won't go into the details of this, again, in the interest of time, but I want to draw your attention back to this parent trial, 13.6% response to active medication, 2.5% to placebo. We had a substantial number of MSM and men who have sex with men and women in this trial, 61.4% of the men. There were some important demographic differences that we control for in our analysis, but there were no differences in treatment condition assignment or in medication adherence between these two groups. And again, this table shows the stage 1, stage 2 responses, and then the average weighted response from both stages. In the top row are men who have sex with men and men who have sex with men and women, and in the bottom row is men who have sex with women. And you can see that the treatment effect for the men who have sex with men is 14.7. That's higher than the treatment effect in the parent trial, and a number needed to treat of 6.7 compared to a number needed to treat of 9 in the parent trial. And this was really a wash in the men who have sex with women group. The treatment effect that was a 2.2%, that's lower than the placebo in the parent trial, and a number needed to treat of 41. This was surprising and honestly a little confusing and not what I was expecting when I thought we were going to see a disparity story here. And these are some hypotheses about why. Maybe this is about the context of use, because this whole talk has been telling you that meth use among MSM is qualitatively different in many ways from meth use among MSMW. And so maybe this is about impulsivity. This is a story of impulsivity and compulsivity, because we know that naltrexone's been used as an anti-craving medication. It's been used for other disorders like gambling disorder that have the impulsivity and compulsivity as a prominent feature. And in fact, there are some suggestions from the data, although the sexual behavior data was limited in the study, that maybe there is something different about chemsex, even among the MSMW compared to chemsex among the MSW group. And maybe this is a story of minority stress. You know, we know that minority stress is associated with greater emotional dysregulation and negative affect, and it's also associated with higher rates of methamphetamine use. So maybe a medication like bupropion, that again is FDA approved for the treatment of major depression, is targeting negative affect and emotion dysregulation here and helping people reduce their use. These are just hypotheses and conjectures that I really hope to work with folks to investigate in the future. But the takeaway here is that we really do have some options for harm reduction. So again, just in summary, among MSM, methamphetamine use is associated with chemsex. Chemsex is associated with elevated risks of HIV transmission and infection and worsening HIV outcomes. Contingency management may be particularly effective at promoting abstinence initiation, but CBT is maybe more effective at reducing HIV risk. Psychosocial interventions for MSM really have to address chemsex, including how to address the social connections and sexual fulfillment that people will still want to have in their lives without meth. Harm reduction is a crucial tool given the number of MSM who have non-abstinence goals when it comes to methamphetamine. And medications like mirtazapine and combination XR naltrexone and bupropion may be particularly effective for MSM who use methamphetamine, though we still need more work to replicate that and really understand why. So I just want to thank you all for your attention. Again, thanks to the HIV Center for the invitation, and thanks to my co-presenter, Steve. And now we can open it up to questions.
Thanks, Jeremy, and thanks, Steve. That was really impactful. And thanks again for sharing all that research. So let's jump into the Q&A. If you have a question for Dr. Shoptaw or Dr. Kidd, please enter it in the chat for the Q&A feature, and I will read it on your behalf, or you can use the raise hand feature and I will unmute you. We have questions coming in.
While we're waiting for people to send questions, I have a question for Jeremy, since there's a second here. And that is chemsex something that deserves some sort of interventions on its own? Or, you know, to the extent of emphasizing health, is there a healthy amount of chemsex that you can have? And how would you know you're in trouble?
I think that's a great question. And it reminds me of a study that was done, or at least started by Matthew Mimiaga at Fenway, looking at it was a sex party based intervention. So can we bring harm reduction in to the setting of chemsex and actually like make it part of chemsex? And it was designed to work with the hosts of sex parties to bring harm reduction messages into those parties without kind of changing the mood. And unfortunately, for political reasons that are beyond the scope of this, that study was shut down early. But I think it's a really interesting idea. Like, can we develop interventions that help change the risks associated with chemsex? When I work with clients, I often talk about many of the harm reduction things that I mentioned in terms of concomitant drug use, in terms of not using alone, and I think PrEP and PEP are big things as well. And I think that one of the things that if for those of you who are prescribers, and maybe not in settings where traditionally PrEP or PEP are prescribed, that we can be important places where people can come to for PEP, because, you know, my patient may not feel comfortable going to the ER, but they can give me a call and I can prescribe them something and then refer them to somebody else. And so the idea, I think here, for me, at least in terms of that, is sort of no wrong door. and sort of thinking about where can we implement these strategies, maybe in places where they haven't traditionally been. The question about, is there a safe amount of chemsex? I don't know. I think that would be like, I don't know that I've ever looked at that to see if there are sort of different like phenotypes of chemsex and like if they're associated with different levels of risk.
Thanks, Jeremy. Justin, go ahead.
Hi, thanks, both of you. This question is probably more for Steve. Steve is and actually, I'm probably going to follow up by email because these are probably more detailed than we can get into now. But as you know, we have that R21 to look at stimulant use, but particularly meth use in Black sexual minority men, and we're hoping to do that. We're hoping to do that with the existing data from that networks and neighborhoods cohort study, but due to disruptions with COVID, we didn't have the type of retention I think that we would have needed to be able to do that. So we're now hoping to recruit current methamphetamine using Black sexual minority men and then be able to follow them over time. But we're having trouble getting into those networks. You know, and it seems like the men who are currently participating, you know, they're underreporting or we're just not making headway into those networks. So I'm just, with all the work that you've done in these communities, just wondering if you have suggestions, advice on recruitment and retention, and I'll probably be following up about that because I imagine you have a lot to say there.
I do have a lot to say, but I'll censor myself so I don't like turn into a lecture here. But I will say, you just asked the question that I am fascinated by. So where have these men gone? And that is the point that I started with, which is, where do men who have sex with men go to meet? I believe the behavior has not decreased in prevalence of chemsex or methamphetamine and sex in MSM communities. And the marker for that is we have a 6% increase of HIV new diagnoses in Los Angeles County. So this is really sort of I think it's kind of all tied together to your question, Justin, by derailing prevention efforts that were moving before COVID to address COVID, because we needed to do that. We've let up the lever on HIV transmission in important ways, in particular groups of like men who have sex with men and racial and ethnic minority men who have sex with men. So, you know, I think that there's your question is a Russian doll sort of thing. There's just thing after nestled and thing after nestled and thing. And importantly, among young men who are having sex with men who are going to have sex, the ways in which these men are organizing and meeting is not known to me. And I haven't met anybody who really knows anything about that yet. And I'm too old to go out and do that sort of qualitative, you know, go into the field and see where men are that I did when I was in my, you know, formative years. But that's the work I think that needs to be done, because nobody has the right answer to that question that I know right now. But I do know there is an answer and we need to find it.
Thank you. And do you think do you think there's important differences by race and ethnicity?
Who knows? I think, who knows? You know, sure.
Thanks. I think so too.
Thanks, Justin. May, go ahead.
Thanks. Hi, Dr. Shoptaw and Dr. Kidd. I work in the field with children and adolescents, so I don't know very much about the population that you're talking about. So I wanted to go back to something that Dr. Shoptaw said at the very beginning of his talk that really intrigued me, and I hope you'll be able to unpack it a little bit for me. But you said that gay and bisexual men carries culture with it, and that was somehow different from referencing men who have sex with men, or the MSM population. So I'm kind of wondering what you meant by when you said carries culture with it, and then sort of trying to understand what it means then when you use the terms gay and bisexual, or think about those groups, versus when you think about MSM or MSM/W groups. Like, what is the culture piece? And then how does that change how you approach or think about those populations?
That's a brilliant question. And it's such a privilege to be sitting in the chair to ask the question and to have the experience of finding these answers. But gay and bisexual men largely adhere and buy into a culture. It's part of an identity. It's a shared identity across men that they're gay or bisexual, and that they're open with it. Their families may know about it. They're out in communities. They're accessing community resources. They may go to gay spaces and gay venues and prefer that over dominant culture spaces and venues. Among men who have sex with men or sexual minority men, we're talking about, oh, and by the way, within gay and bisexual, there can be different culture groups. So there can be Black gay men or gay Black men. And by the way, the order of how you say that makes a difference. A gay Black man may be somebody who feels comfortable being gay and is not as a part of a Black community, whereas a Black gay man may be somebody whose links and community affiliations are mostly within the Black community, but somewhat less in the gay community. And it works the other direction as well, that community agencies may have more emphasis on Black gay men, Black culture, and focus on men who are Black and gay, or gay Black men, which is a large gay, broadly serving institution that has some programming for Black men. So that's how that works. So those are the cultural that's a very deep, social epidemiology sort of, or ethnography sort of thing. Among men who have sex with men, they could be people who have absolutely no connection culturally or identity-wise with gay or bisexual. So they may not even think of themselves as gay or bisexual men, or may even have a hard time seeing themselves as a man who has sex with men. So with them, we're just talking about behavior, the sex between men. So that's the essential difference.
So,
but it's an important one.
So would you say that the group men who have sex with men, though, does that include, or you think of it separately from gay and bisexual men?
So good question. So among gay and bisexual men, most will agree that they are men who have sex with men. Men who have sex with men will include gay and bisexual men and other men who don't identify.
Okay. And so it seems so complicated, and these are the things you are thinking about as you try to develop intervention and intervention approaches. It's like a very heterogeneous, or the potential for a lot of heterogeneous cultural aspects that you're thinking about as you're trying to approach intervention. So
yeah, I'll leave it to Jeremy to talk, but it also has to do about acceptability of interventions. So, some of the greatest pain I've heard is from, say, a race ethnic minority person who feels not at home in their race ethnic minority communities because they're gay. And they also don't feel at home in gay communities because they're racial ethnic minorities. So these culture concepts are important, and it kind of helps understand how to best develop an intervention and scale it up, and how to meet the men you're going to want to meet, because you're not going to meet all of them. You're not going to hit everybody. This is like seriously not, this is more of a cafeteria line. It's not something that you can have one service and that's what you deliver.
Thanks so much.
I think this sort of drives home the point too, that like why it's important to think about implementing interventions in a variety of different settings. Because like I was talking with somebody from Howard Brown a couple of weeks ago, which is an LGBT community health center in Chicago, and they have a really robust substance use treatment program. But they were talking about that many of the folks they serve feel really uncomfortable coming there, especially if they don't identify as gay or bisexual. And so they have a back door that people can come in because they want the treatment, but they don't want people to see them that way, or they don't. And so, as Steve was saying, you know, we're not going to reach everybody in every setting, but if we can think about how to implement these interventions in a variety of settings where people are already accessing care, that might not always be at like an LGBT space.
I like to use New York as a great example of what Jeremy's talking about, where when you test positive for a sexually transmitted infection, you can get a referral to methamphetamine assessment and care. So that co-occurring sort of service unit that really addresses this issue of chemsex, infectious diseases, substance use, all of that sort of thing in the same space is really an important shift in thinking. And New York in many ways has led the way in this sort of thinking.
Thanks so much for your thorough answers. It's helped me understand the culture a bit better.
Sure.
Thanks.
Thanks, May, for your questions. Let's jump to Susan Tross. Susan says, fantastic presentation, of course. Thinking about community and Steve, Kathy, and Jeremy's work, what about the role of peers in the delivery of interventions? Can you speak to that?
Yeah, and I think that many of these interventions that exist in the community, as well as ones that have been studied, have been led by peer. And peer means, as Steve was sort of alluding to, peer here can mean different things, because a peer in what way? A peer as an MSM who uses meth, a peer who's an MSM who doesn't use meth, somebody who identifies as gay and bisexual. So I think it's important to think about who the client is and whether the person working with them really is a peer. So that I think is one consideration, but I think there's huge power in that, both in being able to reach people and bring them into services, as well as making sure that those services are acceptable. I will say that one of the kind of things that I see a lot, though, in the peer-led spaces that I've worked, have been a real predominance of 12-step and like crystal meth anonymous, which I don't want to like bash, but I don't think it's for everybody. And so I want to just sort of like give that sort of that footnote that sometimes a peer may share the experience of being an MSM with used meth, but their treatment and their goals in treatment, or what recovery means to them, may or may not be similar to the person. So I guess that's just to complicate the idea of a peer.
Well, and even further complicated, you could have peers who are gay and bisexual men who are service providers. So they could be physicians, they could be nurse practitioners. And I have an example of Justin Alves, who's in Boston University, who is a gay man and nurse practitioner. And he has kind of developed this idea of using oral naltrexone tablets for like 2 or 3 days. Milo Santos has kind of come up with this idea, as Jeremy was talking about, of, you know, having them, for people who are planning to go party on stimulants, give them 1 or 2 tabs of naltrexone. As Jeremy showed us, it's not going to do anything to their methamphetamine use. It's not going to change their experience, but it would block fentanyl if fentanyl was mixed with the methamphetamine that they bought. So that's a grassroots sort of peer-based generated intervention that would not happen if you had dominant culture scientists out there trying to develop this. They wouldn't have thought about that. So, you know, I do think that the culture and peer context extends to the provider as well as to the participants who are delivering the interventions in a more traditional way.
Thanks, Susan, for your question. I hope that answered it sufficiently. Next, let's go to Ray. Ray, you can go ahead.
Great, and I think the question I had was answered, so this is more of a comment now, just on some of the things that have been saying, and I really appreciate all of the discussion today. You know, having delivered therapy like to people who have a crystal meth use disorder, you know, I think everything that you were speaking to is on point. I think the thing about culture, one of the things that I've really observed in the city is this, you know, the intersectionality of race substance use, HIV status, and sexual orientation, and how those really drive people's the support networks that people have. So, you know, there's a CMA is largely a white gay man organization here in the city. So there was a meeting, there was a closed meeting called Ike and Tina that was specifically focused on Black sexual minority men and trans and trans people who, you know, in the city, where people didn't feel that the racism, didn't feel the objectification that sometimes comes from these other meetings. So there were these niche groups that would develop but you know, that I wouldn't know about unless my patients told me about them. But I mean, and this is what drives a lot of my work now about intersectionality and stigma and, you know, and discrimination, is about how individuals who live at these intersections of multiple forms of marginalization navigate these supportive resources. Because, you know, we know that, you know, this, you know, stigma and discrimination manifests in all kinds of environments, even among, you know, those who are already marginalized. So I think it's really on point that, you know, as we talk about adapting and identifying where these people are, that, you know, we think about how these identities really shape, you know, who, you know, where they concentrate, where these individuals concentrate, and kind of the support they have available to them. I know, like on Grindr, you know, there's a whole like there's a whole like language of like emojis and capital T's that really help people identify with, you know, people who also use meth on these platforms. And, you know, and I think that there are other offbeat, like other apps that, you know, aren't so white centric that, you know, that people use as well. And so I would encourage people just to kind of check in with their patients to find out what are the emojis, what's the things that we should be looking for when we're trying to target the population. But yeah, thank you so much for this very I think the last thing I'll say is around chemsex, Jeremy, and thinking about, because most of the people I've worked with we're presenting for methamphetamine use disorder, and so chemsex was just it pretty much went without saying that, like, the sex that they were having involved was under the influence of methamphetamine use. And so I think the harm reduction around that was really important, because we see sex as a basic need, and so we can't, you know, so you can't prescribe abstinence, right, for sex, but unpairing that methamphetamine use and the sexual activities, it was really challenging. So I'm just, you know, interested in, I'll keep following your work and just seeing what recommendations you might have, and just how best to kind of, you know, untangle those things for somebody who realizes methamphetamine use is pretty harmful to them in any amount, but yet they still want to continue with their, you know, livelihood. So yeah, thanks.
I think that's a great point. And it's one of the real challenges, I think, is helping people still have fulfilling sex lives that are, like, we can just be honest, and it's not going to be the same as if you're high and you're using meth. And I think sometimes being honest about that is like helpful too, and not pretending that it is. But I've learned a lot from my clients, I think, about when it comes to hookup apps and things that are helpful to them, because those still tend to be a way that people meet partners for sex, but as you alluded to, it also is a place where people get offers for drugs too. And so clients have helped me learn strategies that I can share with other people. So things like turning off push notifications so that you're not getting triggers unexpectedly, setting aside like dedicated time, like I'm going to get on Grindr, but I'm going to do this at my house when I'm like relaxed and I'm not stressed about something else, and maybe other kinds of triggers and urges are sort of minimized. And so being really intentional about that, as opposed to maybe the way that these apps were designed, which is where they can follow you around anywhere. But as you sort of alluded to, the drugs can also follow you around anywhere. And the thing that I neglected to mention as well is the relationship between methamphetamine use and sex work. And so thinking about also the ways in which when we ask people to change their behavior, or when people are coming to us to change their behavior around methamphetamine use, that may have real implications for their livelihood as well. And in some cases that people decide that means they can't do sex work anymore. And so then job training becomes really important in helping people find other sources of work. Or connecting people with organizations like SWAP in Brooklyn that can help people be part of peer communities and talk about ways to do sex work in ways that minimize their exposure to drugs.
I would like to build on your point, Jeremy, because that's brilliant. I think, one of the things that Raymond, you're raising is an important issue. And I've built this into my career, and it's always disarming for my patients who I see in my therapy practice, but it's also part of what I do in my scientific work. And that is the first session we talk about that your homework is to get laid without using drug between now and the next time I see you. Many of the 12-step communities don't accept that sort of an intervention, but for men who are gay men, where having sex with other men is the central point of the identity, pulling that drug-affiliated sex out of the sex repertoire leaves a hole, and you've got to be able to put that back. And my thesis is, it is always better to experiment with new behaviors when you're in treatment than to leave that for later after you get your methamphetamine issue under control. So I do believe, like everyone is talking about here, that we have a responsibility to stay sex positive, to be able to build having healthy sex as a regular goal of life, and that as a regular goal of life, people can have problems with meeting that goal and can look to others to find ways to solve the problem.
Great discussion. Thanks, Ray, for your comments. We do have some more time for questions, so feel free to enter them in the chat or raise your hand. Thanks, Karen. We have a question from Karen. Could you speak to the healthcare provider side of things? Many people we train through the AETC who are working with clients get the harm reduction concept, but in terms of putting it into practice, there's still a lot of stigma that gets in the way. Compounding this is the shortage of experts available for high quality treatment referrals, which is an enormous barrier to even getting to good evidence-based treatment. So there are a lot of bottlenecks to access, and that leads to care team demoralization. How can we bolster the helpers?
So I want to make sure we get you information about that training, first of all, about the getting off intervention, because I think that is something that can be implemented in a variety of treatment settings by people at different levels of training and professional background. But I totally hear what you're saying, that like sometimes it's really hard to refer places to treatment, MSM, with methamphetamine use disorder, to treatment, because so many treatment settings don't really do a great job in treating that community. We're really fortunate, as Steve said, to have some places in the city that are accessible and that I think do a really good job of examining that intersection. But it's really hard, because some of the places that I would refer a lot to in the city for substance use disorder treatment, I don't know that I would refer this population in the same way. So, I mean, I think from the harm reduction perspective, for me, it's been about getting to know the places in my community that are doing good harm reduction work. So the places that are doing either, like, I'm gonna just give some names, like Crystal Clear program at Sinai, I think is one, GMHC, other places that I think do kind of get this intersection, but also getting to know your local syringe services program, getting to know the pharmacy down the street from the clinic. And again, I talked about like going in and trying to get naloxone or get syringes and seeing what that's like for me as a cis white gay man, and then sort of imagining what that's like for my patient who doesn't speak English and is trying to navigate that system, and really developing a relationship with that pharmacist too, to sort of help them understand what I might be sending my clients and patients there for. Those have been some of the most successful, I think, ways for me to implement harm reduction in my practice, because, right, like I don't have the ability to distribute syringes as a psychiatrist, like I depend on a pharmacy for that, but getting to know the folks in my community so that when I'm recommending something to a patient, I sort of have an idea of what they're going to encounter on the other end, because there is a lot of stigma, even within sort of traditional harm reduction spaces, either when it comes to methamphetamine use, because they're really focused on opioids, or when it's about a person who's MSM going into those spaces. I don't know if that partially answers the question.
think I also want to build on your your comment, Jeremy, and that is that the COVID epidemic has really put a grind on all of us. And so many of the agencies that were available and were healthy and were engaged and had community people linking with them so that harm reduction happened as part of living are gone. And also, many of our people who are in these situations of using methamphetamine are being ground under by the COVID epidemic. They didn't have jobs like us that you can sit at home and do grand rounds in New York City. You know, it's like they didn't have that privilege. And so a lot of people have been denied for a long time. And so the frontline service worker gets all of that. So if you're somebody who's delivering services, this is happening. What I have to do for worker health is I have to do a debriefing with my staff about once every 6 months. And I go in and we talk about it and they'll cry and they'll talk with me about how they're at the end of their ropes. Burnout within our sector is a real big problem. And this may be a place where AETC could develop some programming to be able to support either learning communities or being able to do some sort of programmatic debriefing of the frontline staff and the folks who are coming into contact with the folks who've been ground under by the COVID epidemic and the ways in which doors have been shut and they're not reopening. So I think your question is a really important one. It's something we're working with here in Los Angeles, but it's really something that is grinding on every single one of us.
Thank you both for those responses. And Karen says thank you as well. And thank you both for your great work. Thanks, Jeremy. May had earlier mentioned her work with youth and adolescents. So there's an upcoming webinar, May, and others who are interested in the chat. Any other questions? If not, Bob, I'll turn it back to you.
Okay, thank you, Stephen, and thank you, Steve Shoptaw. Thank you, Jeremy Kidd. That really was pretty remarkable. And Steve Shoptaw, you know, you've always been, not only you're a good friend and colleague, but you've been a mentor to me for many, many years. And I see Jeremy Kidd will be becoming a mentor to me as well. Got a lot to learn from both of you, and this was great for all of us. So thank you, thank you. Okay, everyone, thanks for being here. Again, a reminder, I hope to see you at our very next rounds on February 9th. And yeah, February 9th, just want to make sure I have the right date. And stay well, be well, and everyone take care. Bye-bye.
Thanks, Bob. Thanks,
Thank you.
Theo. Thanks, Stephen. Jeremy.